पेशंट हे त्यांना वेदना होत असतात म्हणून येतात आणि त्यांना ज्या वेदना होतात ह्या वेदनांचं निदान आपण अत्यंत अचूकपणे जर केलं तर आपल्या असं लक्षात येईल की आपण लहान असताना आपल्याला आपले आईवडील आजी आजोबा काही गोष्टी सांगायचे. या गोष्टींमध्ये आपल्याला बऱ्याच वेळेला ती गोष्ट अशी असायची की एक राजकन्या असते आणि एक राक्षस असतो. तो त्या राजकन्याला पळवून नेतो आणि मग एक राजपुत्र येऊन त्या राजकन्याची सुटका करतो आणि त्याच्यामध्ये तो जो राक्षस आहे त्या राक्षसाच्या दारामध्ये एक पिंजरा असतो, त्याच्यामध्ये एक पोपट असतो आणि त्या पोपटाच्या उजव्या पायाच्या करंगळीचं नख तुम्ही ओढल्यानंतर तो राक्षस मरतो. तर ही जी गोष्ट आहे ह्याचा आपण बोध असा घेतला पाहिजे की आपल्या शरीरामध्ये ज्या वेदना तयार होतात ह्या वेदना सर्व पाठीमध्ये पूर्ण पाठीमध्ये तयार होत नाहीत. या वेदना तयार होण्याची जी जागा आहे ही अत्यंत छोटी, अत्यंत सूक्ष्म 1 सेंटीमीटर पेक्षा कमी जागी असते. जेव्हा वेदनांची निर्मिती एवढ्या छोट्या जागी होते तर मग त्या जागी पोचण्यासाठी आणि ती जागा दुरुस्त करण्यासाठी आपण मोठ्या इन्सिजन्सची आणि मोठ्या ग्लॅमरस सर्जरीची काहीही गरज नाही. मी स्वतः गेले 19 वर्ष स्पाइन एंडोस्कोपी फक्त करतो आणि 34 वर्ष मी एकंदर प्रॅक्टिसमध्ये आहे. तेव्हा मी तुम्हाला हे पूर्ण विश्वासाने सांगू शकतो की आपण जे काय शिकतोय, आपल्याकडे जे बोललं जातं ह्याच्यामधल्या बऱ्याच गोष्टी ह्या जुन्या झालेल्या आहेत. माझ्या कलिग्सनी डॉक्टर भालेराव, डॉक्टर काचेवार आणि डॉक्टर गांधींनी तुम्हाला बऱ्याच गोष्टी सांगितल्या. पण आपण येणारा जो काळ आहे याच्यामध्ये 2 महत्वाच्या गोष्टी लक्षात ठेवल्या पाहिजेत. आपल्याकडे येणारा प्रत्येक पेशंट हा त्याच्या समस्येच्या निराकरणासाठी, त्याच्या प्रॉब्लेमच्या सोल्युशनसाठी आपल्याकडे येतो. आपण जर तो प्रॉब्लेम सोडवू शकत नसलो तर आपल्या शिक्षणाला तसा अर्थ काहीही नाही. आणि आजपर्यंत बाबा वाक्यम प्रमाणम असं जसं म्हणतात तसं डॉक्टर म्हणतील ते ऐकून घेणे, मान हलवणे आणि ते फॉलो करणं असं होतं. पण सरकारने कायदा करून जेव्हा आपल्या पेशंटना आपले कन्झ्युमर केलेले आहेत त्यावेळेला तुम्ही एका मर्यादेपलीकडे तुम्हाला काय वाटतं हे त्यांच्यावरती लादू शकत नाही. तुम्ही एखाद्या गोष्टीचा निर्णय घेताना त्यांच्या संमतीने तो निर्णय घ्यायला लागतो आणि ज्या क्षणाला तुम्ही पेशंटशी हा विषय त्या पद्धतीने बोलायला लागता त्यावेळेला तुमच्या असं लक्षात येईल की पेशंटना सर्वात जास्ती भीती, सर्वात जास्ती उत्सुकता आणि सर्वात जास्ती त्यांचे प्रश्न हे आपल्या वेदनेबद्दल असतात. मी जी काय सर्जरी करतो त्याच्याबद्दल हे एक चित्र दाखवलंय. याच्यामध्ये हे जे काय या गोलात जी गोष्ट दिसते आहे ते माझ्या सर्जरीचं इन्सिजन आहे. माझं इन्सिजन सामान्यपणे 8 मिलीमीटर असतं आणि या इन्सिजन मधून मी मेजॉरिटी स्पाइन सर्जरी करू शकतो. आतापर्यंत करतोय, अजूनही पुढे करीन. याच्यामध्ये हा मुद्दा जो आहे की एवढ्या छोट्या जागेतून आपण जे करतो हे कसं काय करता येतं, तर याच्यामध्ये आपण एक लक्षात घेतलं पाहिजे की मूलभूत प्रश्न याच्यामध्ये असा आहे की आपल्याला ज्या वेदना होतात या कुठून येतात आणि त्या वेदना आपोआप बंद का होत नाही. Where is the pain coming from and why is it persisting is a fundamental question which all of us have to apply our mind and try to answer, because that is the main question which makes the patient come to you. पेशंट जेव्हा आपल्याकडे येतो त्यावेळेला देर आर 2 इश्यूज इन दिस. एक म्हणजे डॉक्टरच्या मनामध्ये अनिश्चितता असते, अनसर्टॅनिटी असते आणि पेशंटच्या मनामध्ये भीती असते. कशाबद्दल, तर ह्याच्यामध्ये जे धोके आहेत. कारण आपल्या स्पाइन सर्जरीबद्दल, आम्ही स्पाइन सर्जन्स आहोत पण स्पाइन सर्जन्सना ह्या गोष्टीची पूर्ण कल्पना आहे की सगळ्या सर्जरीजमध्ये फक्त आमची एकच अशी दुर्भाग्यपूर्ण सर्जरी आहे की जी फेल होऊ शकते. म्हणजे काय, तर पेशंट सर्जरी केल्यानंतर सुद्धा त्याच्या तक्रारी तशाच चालू राहू शकतात. हे आजच्या युगामध्ये, आजच्या काळामध्ये 2018 मध्ये हे पेशंटना मान्य नाही, आपल्यालाही मान्य असण्याचं कारण नाही. त्यामुळे ह्या आपल्या अज्ञानाचा जर आपण विचार केला, आपल्या अनसर्टॅनिटीचा जर विचार केला तर त्याच्यामध्ये आपण हे लक्षात घेतलं पाहिजे की ही अनसर्टॅनिटी जी आहे ही आपल्या अज्ञानापोटी आहे. आपल्याला बऱ्याच गोष्टी माहीत नाहीत. आपल्याकडे काय झालंय की मेडिकल कॉलेजमध्ये आपण शिकत असताना आपल्याला आपले सर, आपल्या मॅडम आपल्याला गोष्टी शिकवतात, पण ते जे शिकवतात हे काळानुरूप जर कालबाह्य झालं असेल तर ते बदललं पाहिजे. आणि मला असं वाटतं की स्पाइन सर्जरीमध्ये ती वेळ केव्हाच उलटून गेलेली आहे. आपण जे करतो याच्याबद्दल आपण अत्यंत सखोलपणे विचार केला पाहिजे की आपण हे कुणासाठी करतो, का करतो, हेच का करतो. मग तुमच्या लक्षात येईल की आम्ही ही जी नवीन सर्जरी करतो ह्याच्यामध्ये शास्त्राच्या दृष्टीने जी जी प्रगती झाली आहे ही सर्व प्रगतीतली सर्व गोष्टी आम्ही त्याच्यामध्ये इन्क्लूड केलेल्या आहेत. आणि हे अनसर्टनिटी आणि रिस्क याच्यामध्ये पेशंटच्या मनात असलेली जी भीती आहे ती जर आपल्याला काढायची असेल तर आपण त्याच्यामध्ये आपलं जे शास्त्र आहे हे जास्ती प्रगत करून आपण त्याचं उत्तर काढलं पाहिजे. When the patient comes to you, he commonly will ask you following questions. The first question is, where is pain or claudication coming from and why it is not going away? पेशंट तुम्हाला असं सांगेल की 6 महिने झाले, 1 वर्ष झालं, मी हे करून पाहिलं, ते करून पाहिलं, सगळं काही करून पाहिलं, तरी पण माझी तक्रार बरी होत नाही. असं का होत आहे? खरं बोलायचं तर मी असं म्हणेन की आमच्यापैकी निम्म्या लोकांना या प्रश्नाचं उत्तर माहिती नसतं. आणि त्या ठिकाणी मग काहीतरी स्टाईल बाजी करून बऱ्याच वेळेला क्लिनिशियन असं सांगतो, वेल आय डोंट नो, आय नीड एन MRI, आय नीड दिस, आय नीड दॅट. At the end of that again he will say I don't know. म्हणजे मी बऱ्याच वेळा एक विनोद सांगतो पेशंट्सना आणि माझ्या कलिग्सना. पेशंट तुमच्याकडे येतो, पेशंट सेज आय हॅव सिव्हिअर पेन इन माय बॅक अँड माय लेग, व्हॉट डू आय डू? द क्लिनिशियन सेज आय डोंट नो, आय डोंट नो. सो पेशंटला असं वाटतं की हा एवढा शिकलेला माणूस जेव्हा आय डोंट नो म्हणतो म्हणजे हा काहीतरी भयंकर गहन प्रॉब्लेम दिसतोय, याच्यामध्ये काहीतरी खूप क्लिष्ट काहीतरी गोष्ट आहे. म्हणजे हा माणसाला सुद्धा माहित नाही म्हणजे केवढा मोठा प्रॉब्लेम आहे. सत्य असं आहे की त्या माणसाला खरंच काही माहित नाही. So when the doctor says I don't know, then the patient says, oh okay, then what do I do because I'm suffering? Then the clinician says, you see, you need an MRI scan. When the patient is told to go for an MRI scan, the patient brings the MRI scan and the surgeon or the doctor will look at the MRI scan and say, well, I don't know because the MRI scan shows this, MRI scan shows that. Then the patient says, okay, but then what do I do? मी आता काय करायला पाहिजे इथे? Again the surgeon says, I don't know. तुम्हाला काय माहित नाही, काय हे करायला लागेल, ते करायला लागेल, ऑपरेशन करायला लागेल. पेशंट म्हणतो ठीक आहे, माझी तयारी आहे ऑपरेशन करायची, तुम्ही कराल का? सर्जन सेज येस ऑफकोर्स आय कॅन ऑपरेट यू. पेशंट म्हणतो माझा एकच प्रश्न आहे, तुम्ही मला ऑपरेट केल्यानंतर मी बरा होईन का? आता गंमत अशी आहे की या प्रश्नाचं उत्तर हो असं क्लिनिशियन देत नाही. क्लिनिशियन असं म्हणतो, वेल यू सी, म्हणजे काय आहे, देर इज अ चान्स दॅट यू मे बी ऑल राईट बट यू मे नॉट बी ऑल राईट. So this should stop. This is absolute sheer nonsense. आणि वर्षानुवर्ष हे चालू आहे, याचा आपण कुठेतरी गांभीर्याने विचार केला पाहिजे. आपल्याकडे आलेला पेशंट हा निर्बुद्ध दगड नाहीये, तो जिवंत माणूस आहे, त्याला यातना होत आहेत, याचं निदान आपण करू शकत नाही आणि याला आपण खात्रीशीर उपचार देऊ शकत नाही, याची कुठेतरी आपण जनाची नाहीतरी मनाची लाज मनामध्ये ठेवली पाहिजे. सो द फर्स्ट क्वेश्चन, वेअर इज माय पेन कमिंग फ्रॉम अँड वाय एम आय suffering for such a length of time, has to be answered very properly. Then the patient would ask what is the ideal solution for pain in the leg or pain in the back. And then if you say you don't need surgery, we need to also understand that how do we monitor the non-operative treatment. Now the problem is, you ask any clinician की तुम्ही ऑपरेट नाही करणार, तुम्ही काय करणार, मग ते सांगतील तुम्हाला की मी ट्रॅक्शन लावणार, मी डायथर्मी, मी असं करणार, मी मालिश करणार, तमुक करणार, हे करणार. Then you ask the clinician, how will you monitor? As of today there is nothing, there is no sign, no nothing. People just bluff that they would monitor it by asking the patient again. I mean, that is not monitoring the treatment. Then we go for a question. Patient says, will I be okay after the surgery? For sure. What is the rate of recurrence after the surgery? What are the complications of the surgery? And then, is stabilization must? Now those of you who are active in spine surgery would realize that a stage has come when the industry has been so heavy on our heads that most of us are only talking about heavy metal. And I'm sure many of the surgeons have stopped talking about anything except putting a screw, which is not science, which is not required, and which is actually let's say misunderstanding which is being propagated. आलेल्या पेशंटला काहीही करून तुमच्या पेडिकल मध्ये स्क्रू घातला पाहिजे एवढंच सांगणं हे आपलं कर्तव्य आहे असं हळूहळू ऑर्थोपेडिक सर्जन्सना वाटायला लागलंय. Is stabilization must? What is the evidence for that? What are the hardware costs? Can we combine endoscopy and stabilization? And suppose by some reason, for some reason, if the surgery doesn't work, then what is the rescue or what is the salvage? Then we also have to talk, especially in a medical college, I have to tell you that we also need to pay attention to the training methodologies and how do we bring new people into spine surgery who would do this. Now I have been doing for 18 years, but I don't feel very proud of saying it time and again, because if you ask me, I have only trained about 500 people till today. For a country of 125 crores, as our Prime Minister commonly says, 500 is nothing, not even a drop in the ocean. So what I feel is we need to improve our training methodologies and bring in new people with enthusiasm, with devotion, dedication and focus on spine surgery. Now, if we consider some basic ideas, what is a healthy spine or a normal spine, what is an aging spine, and what is a degenerative spine. The first thing which you have to note that in a degenerative spine, you have a structural failure. There is some structure in the body which is not functioning or is not structurally normal. That's the first thing. And then of course, in aging spine, there is a lack of nutrition. त्याचं उदाहरण द्यायचं झालं तर आपल्या शरीरामध्ये आपण असं समजूया घटकावर की आपल्या घरी आपण कुंडीमध्ये गुलाबाचं झाड लावलंय आणि त्याला आपण पाणी घालणं जर बंद केलं तर साधारणतः महिन्याभरामध्ये तुमच्या असं लक्षात येईल की ते रोप पूर्णपणे सुकून जातं. दॅट इज एजिंग. न्यूट्रिशन कमी होत गेल्यामुळे हळूहळू शरीर आपलं संथावतं आणि बंद होतात गोष्टी. पण डिजनरेशन मध्ये देर इज अ चेंज ऑफ स्ट्रक्चरल फेल्युअर अँड इन ॲडिशन ऑफकोर्स देर मे बी अ डिस्टर्बन्स ऑफ द न्यूट्रिशन. आणि हे जे स्ट्रक्चर फेल्युअर आहे हे दिस इज सिम्प्टोमॅटिक. याच्यामुळे पेशंटना वेदना होतात, यातना होतात, क्लॉडिकेशन होतं. एजिंग इज असिम्प्टोमॅटिक. तुमच्यापैकी बऱ्याच लोकांना जे लकी आहेत, ज्यांचे आजोबा पणजोबा अजूनही हयात असतील आणि ते 80च्या वर असतील, तर तुमच्या असं लक्षात येईल की त्या पिढीमध्ये वेदना होणे, पाठ दुखणे, कंबर दुखणे, मान दुखणे, गुडघे दुखणे हा प्रकार ऑलमोस्ट नव्हता. त्याचं कारण असं होतं की त्यांचं जेनेटिक पूल वेगळा होता, पण ते डिजनरेटेड नाही आहेत. त्यांचं एजिंग फेनॉमिनन हॅज प्रोग्रेस्ड. प्रॅक्टिकली काय होतं की आपण एजिंग आणि डिजनरेशन हे दोन्ही शब्द समानार्थी अर्थाने आपल्या ओपीडीज मध्ये आणि पेशंटशी बोलताना वापरतो, पण त्याचा अर्थ हा वेगळा आहे. एजिंग इज डिफरंट अँड डिजनरेशन इज डिफरंट. नाउ व्हेन यू आर टॉकिंग ऑफ डिजनरेशन in spine, there are 4 areas where there are changes. Those changes are sensed by our neurovascular system and therefore the symptoms arise. त्यामुळे आम्ही नेहमी असं म्हणतो की स्ट्रक्चर फेल्युअर वर्सेस न्यूरोव्हास्क्युलर सिस्टम is what gives the symptoms. Now what are those changes? The commonest change I have shown here is called as a central posterior annular tear. What happens is the annulus gets torn and then you have a nucleus which comes in contact with the nerves and the arteries and veins. Now remember that nucleus is a remnant of notochord, which is a tissue which was representing the spinal areas in the lower animals. Notochord is an extremely neurotoxic tissue. As long as your annulus is intact, you are asymptomatic. तुमच्यापैकी इथे बसलेल्यांपैकी ज्यांची पाठ कंबर मान दुखत नाही त्या लोकांमध्ये अन्युलस इंटॅक्ट आहे असं समजायला हरकत नाही. ज्या लोकांची कंबर दुखते, पायामध्ये कळा येतात, मांडी दुखते, पाय दुखतो, टाच दुखते, गुडघा दुखतो, त्या सगळ्या लोकांमध्ये अन्युलस मध्ये काहीतरी गडबड झालेली आहे. ही गडबड जी आहे ही तुमच्या मेंदूपर्यंत संवेदना पोहोचवण्याचं काम हे या नर्व्स करतात, ज्याच्यामध्ये माशी डॉक्टर बालेरावनी सांगितल्याप्रमाणे आणि डॉक्टर काचेवारनी सांगितल्याप्रमाणे सायनोव्हर्टिब्रल नर्व आहे, हे सोमॅटिक नर्व आहे, ही सिम्पॅथॅटिक सिस्टीम आहे. दुसरा जो चेंज आहे हा चेंज आपल्या डिशच्या पोस्टरोलॅटरल कॉर्नरला होतो. त्या ठिकाणी काही रासायनिक बदल होतात, केमिकल चेंजेस होतात आणि त्यामुळे पायामध्ये वेदना होऊ शकतात, सायटिक पेन होऊ शकतं. तिसरा जो चेंज आहे हा या फॅसेट जॉईंटच्या अँटिरियर सरफेसवर होऊ शकतो, ज्यामुळे तिथला टिश्यू हायपरट्रॉफी झाल्यामुळे फोरामेन नॅरो होऊ शकतं आणि त्यामुळे पेशंटला क्लॉडिकेशन होऊ शकतं. आणि चौथी गोष्ट ह्या जॉईंट मध्ये होऊ शकते. फॅसेट जॉईंट इज अ सायनोवियल जॉईंट and it can be affected by all forms of arthritis and therefore the patient can get back pain. So please remember that there are only 4 significant areas in the spine which can give pain. Number 1, posterior annular tear. Number 2, posterolateral annular tear. The changes in the front of the facet joint and changes in the facet joint. Now these changes could be also in the form of fragmentation of the nucleus and herniation of the nucleus. Apart from this, there is nothing in the spine which will give pain. I am not talking about trauma, infection and tumors. We have already heard our colleague talking about the MRI appearances of those red flags. So we are not talking of that. We are talking of a degenerative spine which manifests like this. Now, this is a very important concept which I am trying to tell you, is that the interface at this annular tear that is the interface between the inside of the disc and the outside of the disc, because of the torn annulus, is called as a pain generator, because there is inflammation at this area. So what is a pain generator? Pain generator is an area in the body where there is an anatomical structural failure, where the body, neurovascular system of the body has reacted to that area. Now, very important, the point is, as a clinician or as a detective, you have to find out where is this pain generator. Now this is a view of the disc from inside, where I put my scope inside. This is the opening in the disc, this is the annulus fibrosus, this is the posterior annulus, this is the epidural tissue where the vascular reaction is seen, and commonly there is neurovascularization as well as neurotization, which gives pain. So our duty is to find out where is this pain generator, or we must understand the tissue origin of back pain and sciatica. Now let me tell you one thing again. पूर्ण स्पाइन मधून, पूर्ण पाठीमधून वेदनांची निर्मिती होत नाही. फक्त काही सिलेक्ट जागी वेदना निर्माण होतात, आणि त्यामुळे ॲज अ सर्जन तुमची ड्युटी दोन आहेत. एक, तुम्ही ती जागा शोधून काढली पाहिजे. तुम्हाला हवंय त्या पद्धतीने शोधून काढा. पेशंटची तक्रार ऐका, MRI स्कॅन करा, डिस्कोग्राफी करा, ब्लॉक्स द्या, whatever. And number two, you must restrict to targeting that pain generator so that your surgery need not be from posterior midline, or your surgery need not be a big surgery where you have cut open. Now we have already published on this. This is a publication which we did in 2010 talking about in vivo endoscopic visualization of pathoanatomy, etc. याचा अर्थ काय, तर पेशंट तुमच्याकडे आल्यानंतर पेशंट तुम्हाला बऱ्याच काय काय तक्रारी सांगतो. या सगळ्या तक्रारी ऐकून झाल्यानंतर तुमच्या मनामध्ये काही कल्पना येतात की ह्या वेदना ह्या गोष्टीमुळे होत असाव्यात. त्यामुळे मग तुम्ही एक्सरे, CT स्कॅन, MRI स्कॅन काढता. त्याच्यामध्ये तुम्हाला काही वेळेला ती गोष्ट दिसते, काही वेळेला ती गोष्ट दिसत नाही. मग याच्या पुढची स्टेप आम्ही आता केली आहे. म्हणजे मी असं म्हणेन की मॅच्युरिटीच्या दृष्टीने वी हॅव गॉन वन स्टेप अहेड, जिथे आम्ही आमचा एंडोस्कोप फोरामेन मधनं त्या डिशच्या बाजूला किंवा डिशच्या आतमध्ये घालतो, ज्या वेळेला पेशंट पूर्णपणे शुद्धीत असतो आणि पूर्णपणे जागा असतो. वी कॉल इट ॲज अवेअर अँड अवेक सर्जरी. पेशंट 100% जागा असतो, आणि त्यामुळे तुम्ही एखाद्या गोष्टीला हात लावल्यानंतर ती गोष्ट वेदना देते का, हे पेशंट अत्यंत विश्वासाने तुम्हाला सांगू शकतो. फॉर एक्झाम्पल, तुम्ही डेंटिस्टकडे गेल्यानंतर तुमचे सगळे दात डेंटिस्ट काढत नाही. तो तुमच्या प्रत्येक दाताच्या मुळाला पाल्पेट करतो, आणि वेन ही पाल्पेट्स दॅट रूट ऑफ दॅट टूथ, he will tell you that this tooth is gone wrong, or is carious, or is inflamed, or whatever. So that is what we do. So I try to emphasize this, की आम्ही पेशंटची तक्रार ऐकणे, त्यानंतर एक्सरे, CT स्कॅन, MRI करणे आणि डायग्नोज करणे ह्याच्या पुढे गेलेले आहोत. आणि पुढे कसे गेलेले आहोत, तर आम्ही स्कोप आतमध्ये घालून ऍक्च्युअल ती गोष्ट पाहतो, त्या गोष्टीला प्रोब करतो आणि पेशंटना विचारतो, ह्या ठिकाणी तुम्हाला बोट लावल्यानंतर, इन्स्ट्रुमेंट लावल्यानंतर तुम्हाला वेदना कुठे होतात. त्यावेळेला पेशंट असं सांगतो की मला नेहमी ज्या वेदना होतात त्याच ह्या वेदना आहेत. ज्या वेळेला पेशंट तुम्हाला ह्या खात्रीने सांगतो की ह्याच माझ्या वेदना आहेत, त्यावेळेला तुम्हाला परत मग त्याबद्दल शंका घेण्याची गरज नाही. आणि ही गोष्ट तुम्ही रिपीटेडली, मी आता ही गोष्ट गेले 19 वर्ष रोज करतोय, त्यामुळे त्याच्यातून काय झालं, तर आता मला समोरचा पेशंट जेव्हा बोलायला लागतो त्यावेळेला त्याच्या बोलण्याचा वेगळा अर्थ लक्षात येतो. तो वेगळा अर्थ काय लक्षात येतो, मी आपल्याला सांगतो 1 मिनिट भरा. तत्पूर्वी मी आपल्याला सांगेन की हे मी एक चित्र अशासाठी बनवलं आहे की हे जे आहे ही आपली ओपन सर्जरी किंवा मायक्रो लंबर डिस्केक्टमी आहे. ही जी आहे ही स्किन लेवल आहे, आणि हे ऑपरेट करायची जागा आहे. ही जी सर्जरी आहे, दिस इज लाईक अ कोन where you have a long incision on the skin and you have a short dissection at the target. ही ओपन सर्जरी आहे. ही सर्जरी पूर्ण भूल देऊन पेशंट बेशुद्ध असताना केली जाते. त्यामुळे पेशंटला होणाऱ्या वेदना किंवा तक्रारी या खरंच त्या आहेत का, डॉक्टरला वाटतं त्या आहेत, ह्याच्याबद्दल कायम संभ्रम राहू शकतो. आणि बऱ्याच वेळेला तुम्ही जी सर्जरी करता त्याचा उपयोग होत नाही, आणि सर्जरीमुळे नवीन काहीतरी व्याधी निर्माण होतात. कारण हे एवढं सगळं जे कापलंय ह्याची काहीही गरज नाही. हे दुसरं जे चित्र आहे ज्याला मी टेंट सर्जरी म्हणतो, म्हणजे तंबू सारखं ते चित्र दिसतं, ज्याच्यामध्ये नवीन काही मिनिमली इन्व्हेसिव्ह नावाखाली या ठिकाणी ट्यूब आतमध्ये घालून त्याच्या आत स्कोप घालून ऑपरेशन केलं जातं, जे ठीक आहे. पण ह्या ऑपरेशनमध्ये आणि ह्या ऑपरेशनमध्ये काहीही फरक नाही. तेच ऑपरेशन फक्त ट्यूब मधून आणि स्कोप आत घालून केलं जातं आणि त्याला मिनिमली इन्व्हेसिव्ह म्हणलं जातं, कारण स्किन इन्सिजन त्याचं छोटं आहे, पण आतमध्ये जे कापलेलं आहे, जे डिसेक्शन आहे ते बरंच मोठं आहे. मी जी सर्जरी करतो ती ही आहे, ज्यामध्ये स्किन इन्सिजन 8 मिलीमीटरच्या आसपास आहे आणि हा मधला जो एरिया आहे हा मी कापत नाही, मी फक्त मसल डायलेट करतो. आय पुट माय इन्स्ट्रुमेंट थ्रू द मसल्स बाय डायलेटिंग द मसल्स अँड देन आय कट at the structure which is the target, which is the pain generator. So our surgery is 100% more or less invasive, more minimally invasive, etc. etc. मला या वादामध्ये पडायचं नाही, पण मी एक गोष्ट आपल्याला परत सांगेन की माझ्या सर्जरीमध्ये पेशंटच्या लक्षणांवरती सर्जरी कुठे करायची हे ठरवलं जातं, चित्रावरती तो निर्णय घेतला जात नाही. Whatever surgery which we do is primarily targeted to the posterior annulus of the disc, because that is the commonest target, and we don't go posterior midline paraspinal, we do not go intramuscular, we do not go transperitoneal, we do not go retroperitoneal, we go paraspinal, intramuscular, below the facet, in the foramen. Now there are some terminologies which I'll just take half a minute to clarify. This red is called as the outside in technique, where you land on the facet, you cut the facet and go inside the foramen. The green is what I do, what is called as the inside out technique, and this blue is called as a far lateral technique, where you go almost 14 centimeters from the midline. I go about 12 and a half, this is about 9 and a half. So that's a little variation, and there are various indications for that, because you change your trajectory as per the target. Target वर आहे, खाली आहे, डावीकडे आहे, उजवीकडे आहे, त्याप्रमाणे तुम्ही तुमच्या स्कोपचं अँगल तिथे बदलता. हे मिलिंदने आपल्याला दाखवलं. याच्यामध्ये दिस इज अ फोरामिनॉटॉमी, आय एम सॉरी, दिस इज अ लॅमिनॉटॉमी. इकडे डोकं आहे, इकडे उजवी बाजू आहे, ही मध्य रेषा आहे, मिडलाईन आहे. दिस इज द ड्युरल सॅक, दिस इज द ट्रॅव्हर्सिंग नर्व विच विल कम आउट ऑफ द लोअर फोरामेन. This is the exiting nerve, this is the pars interarticularis, this is the facet joint, this is the facet joint. Normally we work here, and then we call that this is the axilla of the traversing nerve, and this is where the shoulder of the traversing nerve. In our routine surgery we never ever see the exiting nerve, whereas in our surgery we put our cannula below the pars interarticularis next to the shoulder of the traversing nerve. So we land in the same area as far as surgical target is concerned or entry is concerned, and this area has been called as Cambin's triangle because Dr. Parvez Cambin is an Iranian American surgeon who is now almost in the 90s. He is not active anymore, he is not keeping good health. Dr. Hijikata is also living. Dr. Hijikata is in Taikyo University in Japan. Both of them are very aged now, they are not very active. My teacher Dr. Young and another teacher Dr. Knight are the senior most surviving active surgeons who recently were in Hyderabad, and we had a meeting about 3 weeks back where we had about 240 surgeons interacting on this issue. Now here I have a video for you where you will be seeing the microdiscectomy on the left side, and you will be seeing the endoscopic perspective of the same surgery. Okay, now what you have to imagine is whatever the surgeon is doing here is being seen through the scope which is put inside the foramen. That is actually done like this. The only thing is I have put a little delay here so that you can watch one part of the video on the left and then watch the part of the video on the right. But you can see that this is a very bloody field. You have cut so many structures. The patient is under general anesthesia and you're using big instruments to go there and do certain things. Now this thing is outside the disc. I mean, this is from the posterior midline. You see this probe here, this is a avascular field. Our surgery is under irrigation and under local anesthesia normally. Only in this patient, just to create this video, to show people that we are doing the surgery through this portal rather than this portal. Now you can see I'm irrigating, the irrigation is coming up here, and you can see my instrument here which can be seen at this age. You will also further see some 1 or 2 more instruments. What I'm trying to convey to you is that we do the same target related surgery but our surgery is through the foramen. Now here you will see my instrument on the posterior annulus, which you can see here. Then I am pulling my cannula outside. This is inside the disc. I am now going to cut the annulus here. You will see the instrument there. And then I will put a hook here and then try to mobilize the fragment, etc., etc. So the point of showing you this video is, this is the surgery when done by microlumbar discectomy, and this is the same surgery which I can do under local anesthesia through the foramen. Now we can see that I am using a bipolar cautery as to shrink the collagen of the annulus. This is a bipolar cautery. This works under water, and you can work on a dot. You can work on 1 millimeter. Now this view which you have, the working channel of my scope is 3.625 millimeters, and the scope has an angle of 25 degrees. So I don't see at the horizon, I see about 25 degrees above. This is the straight down microscopic view. Now you can see the hook which I am putting here. You can see the tip of the hook here. So in short, what I am trying to convey to you is that we do the same targeting, but this surgery commonly is under local anesthesia. There is no bleeding, there is no need of IV fluids. We do it under irrigation, and we can use various modalities to achieve same or better results. Now quickly I'll just tell you the anatomy of the foramen. This is the anatomy of the foramen on the left side of L4-5, for example, and I will orient this to this within a minute. There is a body of L4, body of L5, disc of L4-5, superior articular process of L5. There is a nerve L4 coming out. This is the inferior articular process and the pedicle of L4 going down. Now the nerve is like this, and this is the nerve coming out. This is the body superior articular process. So this is the superior articular process. This is the disc, this is the body, this is the body, this is the pedicle, this is the pedicle. So we land little medial to this nerve in the Cambian's triangle and do our surgery. Now this is the Cambian's triangle shown here. The Cambian's triangle has two parts. One part is shown in bluish color, which is actually the disc, and this yellow part is actually the part of the bone, that is the body of the vertebra above, which forms the apical part of the triangle. And commonly we refer to these figures, which are 12 millimeters in height, 18 millimeters at base, and 23 millimeters as the hypotenuse of this right angle triangle. Now these figures come from American cadavers, which are 6 feet tall on an average. For Indian cadavers, we have done this study, which has come to around 11 height, 13 base, 17 hypotenuse. So you can imagine we have about 1 centimeter, 1.3, 1.7 centimeter triangle, and this is the triangle. Now what we do is we always land outside this line, what we call as a medial pedicle line, because this line is the lateral edge of the dural sac. And this red arrow is to show you that I operate from my entry up to the midline from one side. I may also operate from both the sides. So this I call as an acting rectangle, and this rectangle is about 11 millimeter in height and about 16 millimeter at L1 and about 18 millimeters at S1. So it's a very tiny area. तुमच्या करंगळीचं टिप जर तुम्ही पाहिलं तर तेवढ्या एरियामध्ये सर्जरी केली जाते. It's an extremely tiny area. It is not a football field where you're operating. In short, also I'll highlight this, that when you're operating on the right side of the patient, I ask my friends to look at their own right hand, where the thumb is supposed to be exiting nerve, there is a traversing nerve, the metacarpophalangeal joint may represent the dorsal ganglion of the exiting nerve, and we always go in the first web space. We always land here. For the left side of the patient, you look at your own left hand, so it's more easy to visualize what you're doing. I would also bring to attention, especially the student part of our audience, this book which you can read. This is available on the internet, called as Biochemical Origin of Pain. Please remember that in the human body, the pain is only present if you have inflammation. If the structure is not inflamed, there cannot be any pain whatsoever. I'll give an example. Those of you who are putting their elbows on the table and who are sleeping will find that their ulnar nerve will slowly become numb. They will have dysesthesia, but they will never have pain. Whereas if you have little inflammation, it will become painful. Please remember, anything in the body which is painful has to be inflamed. And for the sake of students, I'll just add 1 minute, is that this inflammation is mediated by cytokines called as prostaglandins, interleukins, and TNF-alpha. Common oral painkillers are anti-prostaglandin. The new painkiller nimesulide is anti-interleukin. But unfortunately, we do not have an oral medicine as anti-TNF-alpha. Anti-TNF-alpha is needed because sciatica commonly is mediated by TNF-alpha, which is a cytokine. But the funny thing, the cheapest medicine available, that is steroid, acts against all of them. So many times we use steroid to treat this pain and the inflammation. I would very strongly recommend this book, Biochemical Origin of Pain. Once you read this book, your perspective on pain will entirely change. And I would even go to the extent of saying that do not believe your professors who are telling you things which are old and obsolete. Please read this. This is something which is a key to future. You must understand this much more because you are the ones who are going to be the working doctors in future. Now quickly I'll tell you the algorithm which I use in my patients. Now this algorithm and my matrix, which I'll show within a few minutes, has come out of my experience of 19 years of treating all my patients under local anesthesia. All of my colleagues who have seen me operating, I always operate on a patient who is under local anesthesia, no general anesthesia. We occasionally sedate the patient to make the patient comfortable so that he is able to tolerate some pressure and some discomfort. A patient comes to me with back pain. What I do is I ask the patient, is it in the central aspect or on the sides, and then whether it is vertical or horizontal. Commonly the vertical pain is L4-5, horizontal is commonly 5-1, or I would say if it is horizontal, it is always L5-S1 related, 4-5 may be vertical. Then we ask the patient to do this test, what is called a Mackenzie's test. It is very simple. You ask the patient to lie on the belly face down and without support of the hands try to raise the chest of the bed. When the patient extends the spine, the pain may centralize, that is, whatever pain which the patient is having, which is spread out, going down the leg, etc., it will come towards the midline. Then you give medical treatment or extension exercises, and maybe you can give an intradiscal injection depending on the inflammation. If the pain does not centralize, then commonly we do discogram, where we put a needle inside the disc and try to visualize the changes in the morphometry of the disc and the pain generation that time. Now when we do a discogram, we may see a fragment or may not see a fragment. If there is no fragment, if it is only leaking disc, then we treat with intradiscal injection. If there is a fragment, we remove it. Now here you will find the pain is on the side of the back. It is well localized, it increases with extension, then it is most likely to be facet related pain. And then if it is only mild pain, you treat medically. If the pain is very severe, like in older people, we may use a facet denervation, where we remove or ablate the nerve supply to the facet, which I am going to demonstrate today or tomorrow. Now, this is what I see in my patients. You have a horizontal pain, most common with 5-1, vertical pain, which is most common with 4-5, and pain on the sides in very localized spots, which increases with extension, that is most commonly facet pain. And this is Mackenzie's test. Mackenzie's test is supposed to indicate to you the annular integrity, that is whether the annulus is good or not, whether the patient is going to respond to good conservative treatment or not. If the patient comes to me, he does extension, and if the pain centralizes, then I commonly do not offer surgery because the patient may settle without surgery. In patients where we do a discogram, it is helpful because this is a normal looking MRI, but you will find this is a male aged 22 who came to us with very severe back pain, and this back pain could only be diagnosed by doing this discogram, where you see the dye coming out almost up to the edge of the posterior annulus, even though the outline of the disc is not changed. Please remember that almost all clinicians will be absolutely clueless. They will not know anything what to do in these patients because the MRI looks normal. We should go beyond that. we should put a needle and do a discogram, or put a scope and see the thing at least for a few cases, so that next time when the patient similar to this comes to you, you will understand that it is because of this annular tear. Now quickly I'll tell you about a leg pain, which I'm sure all of you or your friends must have had once in a while. Leg pain is based on understanding which I have published under my name as my sign, and I would tell you something which will baffle you or which will excite you, that the commonest manifestation of L5 related pain is knee pain. Pain in the knee, on the outside of the knee, or inferior pole of patella, or inferolateral pole of patella, or posterolateral aspect of the knee, is almost always L5 related pain. Pain in the heel is almost always related to S1 related problems. In fact, I would even go to the extent of saying that in addition to this, we have commonly seen people with coccydynia and people with pain in the groin where no other cause has been found, which is almost always because of L5-S1 related problem. So if a patient comes to you with lateral aspect of knee pain or leg pain, it's commonly in the dermatome of L5. So please remember here that dermatomes, as you might have learnt in your first MBBS, are 120 years old. They have not been revised by any anatomist till today, except for a few of my colleagues from Turkey who have done this job in last 5 years, where they have tried to revise and reassess and refocus and analyze the dermatomes, because otherwise they are 120 years old. And what has happened is, we also know that because of the interconnecting neurons, dermatomes are not exact. They are not absolutely perfect. There could be an overlap. And grade 2, even though normally is supposed to be L5 indicative, it may be also L4, it could be also S1 in some people. So if the pain is along L5, if it centralizes, that is, the patient lies on the belly and extends the back and the pain comes together, and if you give a distal block, this I will explain with my sign in a minute, then we normally give a conservative treatment in the form of medical treatment, exercises, intradiscal or periradicular injection. If the pain doesn't centralize, if the distal block, that is injection at the end of the nerve, is not effective, if the SLR is positive and with neurology, then we must go for an imaging study. And if the patient doesn't have neurology and pathology as per the MRI decides the treatment, fragment you remove. If there is an annular tear with trapped fragments, which is the commonest cause of discogenic pain, then we remove and clean the tear, we remove the fragments there. If there is no fragment, we give the injection. And for stenosis, we do a foraminoplasty where we work on the tip of the superior articular process, and for instability, we add percutaneous fixation. Let me clarify that I am not against fixation, but I am against inadvertent use of fixation and telling the patients that there is no alternative, which is absolutely wrong. And this is a big fraud going on, where many orthopedic surgeons are just trying to impress the patients by showing the hardware, and they always show very good looking post-op X-ray, but the patient is still suffering, which is not correct. Now this is what I have published. This is my new method of diagnosis of sciatica and related problems. So what I am going to tell you is something very basic. Just listen very carefully what I am talking. When the patient comes to you with sciatic pain, माझ्याकडे जेव्हा बऱ्याच वर्षापूर्वी, दिस इज अ थिंग ऑलमोस्ट नाउ 20 years old, त्यावेळेला माझ्याकडे जेव्हा सायटिका असलेले पेशंट यायचे, तेव्हा मला नेहमी हा प्रश्न पडायचा की हे काय आहे. As in those days, I used to follow what everybody follows even today, that is doing a straight leg raising. I used to ask the patient to raise the leg, and if the SLR was negative, I was totally nonplussed. I had no clue whatsoever to the pain. Then what I did is, as all of you as students know, that we follow a simple dictum in medical examination, that is inspection, palpation, etc., percussion and auscultation. So I started palpating the sciatic nerve. Sciatic nerve from greater sciatic notch up to the ankle, I started palpating in every patient who comes to me with sciatic pain. And I found that there are two areas of the sciatic nerve which are extremely tender. One of those areas is here in the roof of sinus tarsi, where you have the muscle called as extensor digitorum brevis, which is just ahead of the end of the fibula on the outside of the ankle. This is lateral aspect of the ankle. You can see this little toe. And the pain, there was another spot here on the lateral wall of calcaneus which was extremely painful in patients who had S1 related pain, and this was when the patient had L5 related pain. Now you can check it in your patients, you can check it in your friends, you can check it for yourself. When we found that these areas are painful, we started asking a question. Why are they painful? What is it that makes them painful? The problem is the nerve is inflamed. Then we tried to ask a question. Why is the nerve inflamed? The nerve is inflamed because there is a nucleus pulposus which is irritating and inflaming the nerve. Now what is it in the nerve that happens because of this inflammation? Then we found it is sodium channels which go up in the nerve which give the pain. Then something funny happened. I started, after I read that there is sodium channel up regulation, I started injecting local anesthetic here and here in patients who had L5 sciatic pain or S1 sciatic pain. You will not believe that when I inject local anesthetic here, all the pain in the leg and the back goes away. Please believe me what I am telling you. I am not joking or I am not trying to bluff. A patient who has S1 related sciatic pain, you inject here and the pain just goes away. Now, all of us have been taught in our medical school that you inject proximally, you will have a relief distally. One more thing I'll tell you, I also see a lot of patients with cervical radicular pain, and many of them come like this. They hold their hand like this, or they keep the hand above the head and say, "Oh my God, sir, I have so much pain, please do something." Then you ask him, "Why are you holding your hand like this?" He says, "I cannot put it down. The moment I put it down, it is very painful." So what we did, in case of upper limb, we inject at the end of posterior interosseous nerve, or the dorsal radial nerve as we call it, at the base of the first metacarpal, medial to the cephalic vein. Now, you will ask me a question, why is it that when you inject local anesthetic, which is a sodium channel blocker, here the pain of S1 radical goes away? The point is very simple, which has somehow not been highlighted by our teachers. The point is, in case of nociceptor, that is, if you look at an axon or a neuron, there is a cell, there is one branch called as an axon, and there is another branch called as a dendrite or dendron. In case of nociceptor, that is a neuron which is sensing the pain, there is a cell, there is an axon, and the axon has two branches. This is called as a pseudo monopolar axon. So there is an axon with two branches, and whatever happens at one branch is perceived as happening at the other branch. In fact, that is the reason why when you have a disc herniation at 4-5, you get pain in the leg. There is nothing in the leg which is wrong. It is only the nociceptor part of the, or let's say the part of the axon which is going down the leg, which is felt by the brain that has inflamed and that is giving pain. Therefore, I can tell you that when you inject here or here, the problem just goes away. Now, the next question is, how much time will it go away? The real answer is, if the sodium channel level is brought down sufficiently, the pain may go away for a long time. Maybe few days, few weeks, we don't know. Somehow research has not been done in that area. Maybe few of you, when you become senior, can take up this research or something similar. So what I'm saying is, I have my sign which indicates that L5 involvement is present if I feel that the deep peroneal nerve is very, very tender. Now there is one more thing which I came to know after I started studying this. There are people who will come to me with knee pain, where the knee pain is on the outside of the knee, not on the inside of the knee. These will be young people. These will be people who will sit with the crossed legs on the floor, but will not be able to sit beyond 15 minutes, beyond 10 minutes. In fact, the patient will tell you that if I sit like this, after 10 minutes I must make my knee straight. Otherwise it is very painful, or the leg goes numb. Now this is sciatic pain. This is not knee pain. I can tell you in my OPD, every day I see at least 5 to 10 people with knee pain. I mean, they come and tell me I have knee pain, and I find that it is not knee pain, but it is sciatic pain. Now, why is the lateral aspect of the knee painful? Because all of you will remember from your anatomy that common peroneal nerve gives 3 branches to the lateral aspect of the knee, which are called as superior, inferior and recurrent genicular branches, and these are the ones which are involved when the common peroneal is involved. Therefore, the patient has pain in the lateral aspect of the knee. Now, I am sure some of you who might have had pain in the knee must have gone to the orthopedic surgeon, and immediately he must have told you, this is chondromalacia patella. Nothing. Or you have pain in the heel, they will say, this is plantar fasciitis. Nothing. Also, you would see a lot of people who will come with a pain on the lateral epicondylar area, which you would be told, this is tennis elbow. No. This is cervical radicular pain. Now please keep your eyes, ears and brain open, because this is actually what is happening and our patients are suffering. Nowadays, actually, I tell a lot of people, a lot of my friends who listen to me, that most of our patients are suffering not because of the disease, but because of ignorant doctors. And we should stop this ignorance as early as possible. Now, based on my sign, I stage the sciatic pain into 3. Stage 1 is called as mechanosensitization. That is, ती जी नस असते ती हुळहुळीत झालेली असते. This is seen in 80% of the patients, and they present as knee pain or heel pain. The second is mechanical compression, which is about 15% of the patients, which is detected by SLR, straight leg raising, or LASIK sign. And number 3 is a mechanical compression plus neurodeficit, which is detected by routine neurological examination, maybe electrophysiological examination, which is about 5% of the patients. Now mind you, 80% of the patients are moving around today without any diagnosis. I mean, they are misdiagnosed. I can guarantee you that a patient who comes with pain and a young person would always be subjected to merchant's view of the knee and patellofemoral joint investigation and maybe arthroscopy, whatnot. I mean, it's absolutely irrelevant. A patient having heel pain will be subjected to an X-ray and would be told that you have plantar fasciitis and your bone of the heel, that is calcaneus, is growing. Absolutely wrong. Please kindly understand this and try to apply this in your practice. And if you prove me wrong, I will give you a prize of 100,000 rupees. I can openly say this. If you prove me wrong, what I'm saying, I'm open about it. I will pay you for your efforts. Now here what I've done is I've come out with my matrix. Now what do I mean by that? What I mean is I have come out with this idea that there are only 6 groups of patients. Number 1 is knee and heel pain. Number 2 is back pain coming from the facet. Okay, low back pain which is of the facet. Number 3 is back pain coming from the disc. Number 4 is sciatic pain. Number 5 is claudication in a stable spine, and number 6 is claudication in an unstable spine. Apart from that, there is nothing. These are the only 6 symptom presentations in patients who have a spine-related degenerative problem. Now, what is important in this is that if we apply your mind, if you analyze the patient properly, then you will be able to put the patient in one of these groups, analyze him properly, match the algorithm with this, and then treat the patient properly as per the requirement. Now this is a scan of our patient in the afternoon, which Dr. Naikwadi has sent me. He has a herniation here at L5S1. This is a young man aged about 22. Now what I am going to do is I am going to land inside the L5S1 disc. I am not going to cut open anything. I'm going to go about 12 centimeters from the midline and land inside the disc at L5S1 here. Some funny things are happening here. I'm unable to see anything on my screen, but it's okay. So you can see here, this is the disc which is affected. Something wrong. Yeah, probably something is moved. Would you please kindly do the thing? So what I've tried to convey to you is that we have a much deeper understanding of the patient's symptoms. We have a better analysis of the symptoms. And mind you, I did not talk about MRI in the first place. I'm not telling you that unless I get an MRI, you can close it and start again. diagnose the thing in the early part. You can definitely diagnose the thing in the early part if you have a high degree of suspicion. If your mind has been blown away by the MRI and by the heavy metal gang, then you will not be able to diagnose, because at the end of your diagnosis, if you're going to tell the patient that you need a MRI or you need a surgery, then nothing is achieved. Okay, whatever. So that's the answer to your question, that can we diagnose? Yes, definitely we can diagnose. In fact, I can tell you that if, for example, just as a matter of discussion, if out of all of you, if I feel deep peroneal nerve of everyone present here, I can guarantee you that at least 30 people will be there where their deep peroneal nerve will be tender, and I can tell them that they have pain in the trochanteric area, they have the pain in the buttock, they have pain in the calf, they have pain in the heel, they have pain in the forefoot, etc., etc. Just because clinicians are not aware of this problem, they would ascribe that pain to something which is common sense. An unfortunate part is, slowly in spinal medicine, a thing that has happened is that general public has started feeling that medical science is common sense. I mean, somebody comes to me and says, I have pain in the heel. You know, doctor, I changed my shoe recently and therefore I have pain in my heel. So what sort of science is this? Can a change in the shoe give pain in the heel? It can give pain in the heel for a day or two. The moment you again go back to your comfortable shoes, the pain should go away. But this type or this level of science is now prevalent, where a patient feels that a clinician is just a person sitting on the other side of the table without any knowledge, which in some cases may be true. I mean, the clinician may not be really knowing anything about it. He's just bluffing. He's just saying, you know, you have plantar fasciitis and your calcaneus is growing. Absolutely wrong.
So one more thing, if we have an early diagnosis and as per your plan, looking after the Gore sign, we inject the points, or we later on go ahead and inject intradiscally the steroid, and we arrest the pathophysiology or the degeneration of the disc.
Okay, now you see what has happened is there are certain concepts in clinical medicine which have been hammered in the heads of the people. For example, you put a needle inside the disc will degenerate. I say, you see, I put a needle inside the disc only if the patient has symptoms and volunteered for treatment. Okay, I don't catch everyone sitting here and put them under the CM and put a needle. All these talks about certain, for example, discography. The moment I utter the word discography in spinal meeting, immediately people say, oh, it is controversial. I say, who has told you? I mean, have you ever done, heard, read, seen, assisted? Nothing. But you will say that it is controversial. It's like politics, where people have opinions about everything without doing anything, which is not correct. I mean, after all, ultimately, what are we doing? We are trying to help the patient come to a conclusion and a diagnosis. We are trying to come with a shared decision where we are trying to educate the patient, tell the patient this is what it is and this is what can be done. The patient has a choice. The patient can say no. I mean, whenever I talk with my patient, I tell them, I am a clinician, I feel as per my science, you need this. If you don't want, it is okay, I am not your enemy, I am your friend. If you don't do this, if you are not interested, it is fine. But beyond a certain degree, I would refuse to see you, because your adamant nature or your way of looking at my science is not acceptable. I am a learned person, I am not an ignorant person, I am not an idiot like you, for example. So sometimes we have to be very, very blunt about it. Otherwise, clinical medicine is disrespected, not respected by the general public. They feel that any Tom, Dick and Harry can diagnose it. And we hear all those stories. तो माणूस तिकडे गेला, त्यांनी पाठीत लाथ घातली आणि तो बरा झाला. What kind of science is this? What are we talking? At least in academic forums we should not. I mean, socially we know what people talk.
Thank you, Dr. Gore, for giving us a different perspective as far as backache is concerned. I mean, so far we have been seeing only MRI and assigning all those signs and symptoms to our pain. And apart from your Gore sign, I also have a question like Dr. Dowley has. If a person comes to me telling that he has pain all over the body, I mean, backache is there, knee joint pains are there, the heel pains are there, and plus in the pains of upper extremities. So far we have been labeling them as a fibrofasciitis pain. So Is this term can be related with either a discogenic pain or a neurogenic pain from the lumbar area and cervical area? Can it be combined together?
Yes, the answer is very simple. I'll give you, I can give you a very detailed answer, but I'll give you a short answer. You see, there are a lot of female patients especially who would come with pain almost all over. I'll just tell a joke just to make the atmosphere a little lighter. When I was a medical student, when I was in 3rd MBBS, we had devised 2 questions for those people. We used to ask them, तुमच्या केसामध्ये दुखतं का? The patient सांगायचं, हो, केस ओढले तर दुखतं. Then we used to ask them, तुमची जीभ दुखते का? Patient used to say, हो, चावली तर दुखते. थोडक्यात त्या पेशंटला सगळं दुखतं, everything, right from head to the toes. Now we must understand that many of these are female patients, and in female patients the commonest complaint is superomedial angle of the scapula area pain or trapezial pain. This pain is found to be related to a mild deficiency of estrogen. This is the commonest pain in a female patient around the age of 30. Now, if the patient comes to you with pain all over, then first thing you have to nowadays see is that whether the person is exposed to cold air all the time. You see, when you have neuralgia, when you have pain mediated by the nerves become extra sensitive to cold. Nowadays we find people sleeping under an AC or a fan or a cooler all the time, 24 hours of the day, all days of the week, all weeks of the year. Exposing your body to continuous cold always will give you more neuralgic pain. In fact, physiologically, when the body temperature is always 37 degrees centigrade, the God has optimized our body at 37 degrees centigrade. If it goes below 22, the pain will automatically start. That is number 1. Number 2, you ask the patient to stand and put your fingers on the trapezius and you squeeze the trapezius. If the patient says, if there is so much of inflammation, then you have to find out, and you should read the book which I mentioned, that is Biochemical Origin of Pain. Now here is a very significant point which I am trying to tell you, is that our ability to diagnose pain unnecessarily is dominated by structural thinking and by imaging and by diagnosis as per system, like arthritis, myositis, neuritis. This is wrong. We should say this patient is inflamed. In fact, I can send you a link to an article which was written once in New Yorker, which says all of us nowadays are so inflamed. I mean, because of dietary problems, because of lack of exercise, because of bad posture, because of excess use of vehicle, because of pollution, because of exposure to so many things, you are inflamed, and that can give rise to pain. The commonest problem which I have seen in those female patients is you give calcitonin nasal spray, which, as you know, induces endorphin formation in the brain and can relieve that pain to a large extent. Now here I must caution you, there is a new fraud which is coming up and has come up in cities, that is asking every patient to do vitamin D3 and B12. This is absolutely idiotic. There is no science in it. One thing I can tell you for sure, that D3 vitamin estimation is done with normal values taken from Germany. The machines are Siemens-made machines. They follow a nomogram from Germany. German values cannot be applied to Indian values. We have a National Institute of Nutrition in Hyderabad. We have our own values. We should follow that. Otherwise, asking a patient just to do a D3 and B12 is absolutely idiotic. It has no meaning. In a male patient, you will find generally whole body ache is not very common. And one more important thing, if the pain is not inflammatory, that is, the patient says instead of taking anti-inflammatory, the pain is not going away, then it is because of fatigue. Fatigue, that is damnukisa dukhna. What is fatigue? You ask the patient, when do you have this pain? Invariably the patient will say, I have the pain at the end of the day. Or the patient would say, मी पूर्वी 25 गोष्टींचं काम करायचे, पण आता मला 2 पण करता येत नाही. Okay, so that fatigue is there. That fatigue is always because of porosis or occasionally osteomalacia. Apart from this, I have not seen other common causes. Of course, you can always have hormonal causes, you can always have endocrine causes, you can always have many other causes. But commonly I will tell you, bad posture, lack of exercise, pollution, improper attention to diet, eating fast food, etc., etc. So all these things, if you pay attention, probably you should be able to help your patient. Now, with your permission, I'll go ahead quickly. So, this is a scan which shows the cross section, and I would bring to your attention you can see here at L5S1, you can see a central annular tear. In fact, if you see this area, then you will find that the normal concavity of the disc is lost and there is a bulging there. And I can assure you that there will be a 2.5 mm fragment sitting there in the posterior annulus. And this is what is causing the problem. Okay, now I'm coming to a little more complicated topic of canal stenosis. Oh. What's happening? This is not showing what is seen here. Probably the projector is allergic to my style of talking. This is okay, but it should go further. Now, claudication is something. Claudicare means limping, langadne. So when a patient comes to you and says that, you know what, I cannot walk beyond 50 steps, or I cannot walk beyond 1 kilometer. I used to walk 10 kilometers every day, but now I can't even walk beyond 1 kilometer. What you do is, you ask him to fill up this questionnaire. There are 10 questions. This question has been made by Japanese Orthopedic Association, and if first 2 questions are yes, then it's a mild form of stenosis. If first 6 are yes, then it's a moderate form of stenosis, and if all 10 are positive, then it's a severe form of lumbar canal stenosis. Now mind you, I have seen patients where they come to me and say that, you know doctor, I have a problem, I feel very shy to tell you, but when I walk, if I walk 100 steps, I must go to the washroom, otherwise I'll wet my pants. It is as bad as that, and this is classic lumbar canal stenosis involving the sacral roots. Now what we do in these patients is we also ask for a post-void residue. I'll tell you quickly that we had a long discussion once about cauda equina syndrome, and then we came to a question: can we predict cauda equina syndrome? Can we say that this patient is going to have bladder problems after the surgery? Then we came out with this idea of doing a post-void residual urine estimation on ultrasound in every patient above the age of 65. You will be surprised to see that 10% patients will have values in males above 100 with a normal prostate or a moderately enlarged prostate, and in a female with 60 cc and above. These patients are already having a neurogenic bladder. Now these are the people whom you operate and they land up with a retention. And mind you, if you do not tell the patient beforehand, you are heading for trouble. The patient is going to say, you have caused this problem. Now you are liable. And it is true. So I always tell funnily to my colleagues that whatever you talk before the surgery is science. Whatever you talk after the surgery is defense. Please remember, please be very clear in explaining to the patient what you are doing. Then this is again the Camden's triangle, and this is the superior articular process which is pressing on the dorsal ganglion, which is known to cause this problem. And this is the inferior articular process. Now mind you, open surgery cannot solve this problem, because unless you cut this, you cannot solve the problem. The moment you cut it, you are going to say, you know, unfortunately I have to put the pedicle screws, because now it is unstable. And what is happening is, this is from one of the papers in World Orthopedic Journal, where actually the vascular function in the axilla area is affected. I also have some videos where you can see the RBCs running rapidly, and in stenotic it is slowly going like this. So there is a stagnation, there is a reduction in venous return. That is why when you stand or when you walk for some time, the patient gets symptoms. And here, as I mentioned, this is the thing which causes the symptoms, that is the superior articular process or the superior facet of the inferior vertebra. Now, this is a publication which I have done where I call it as a coronal oblique MRI. And I must tell you that routine MRI is again a problem. My MRI specialist colleague can guide me on this. Why is it that when we know that the canal with the posterior elements is a problem, why is it that we take the cuts in the plane of the disc? We should take it in the plane of the facet, because the problem is behind the dural sac. And this is what happens. If you take an oblique cut, this is the ligamentum flavum. Now, there is only one single paper in the world literature of about 5,000 papers which talks about ventral dissection of ligamentum flavum. Now let me clarify in next 1 minute. Here I can tell you that the ligamentum flavum starts from midline, covers the undersurface of the facet and goes to the upper pedicle, and the nerve is going below the pedicle like this. So the portion of the ligamentum flavum above this blue arrow is more important as far as symptoms are concerned. Now, I am sure all of you who do the posterior midline surgery are going to tell me that, but you know, Dr. Gore, when we do a laminectomy and removal of the ligamentum flavum, the patient is okay. I say yes, because you are doing a indirect decompression. I would rather do a transforaminal direct decompression of the dorsal root ganglion. So this is a dissection, what we call as a ventral dissection. That is, we are looking towards the inside surface of the lamina. Okay, we are looking from the front. We are not looking from behind. We are looking from the abdominal aspect. We have done a vertebrectomy, we have removed the dural sac, and we are looking at the lamina and interlaminar area. Here you will see this is the medial pedicle line, and there is about 11 millimeters of ligamentum flavum lateral to the medial pedicle line. This ligamentum flavum cannot be removed by open posterior midline surgery. Impossible. Cannot even be seen, touched or acted upon. This is a routine oblique MRI, which actually should be the norm, because here you will see the roots are seen very well. You can see the dorsal root ganglia there, and you can also see the Cambin's triangle, and you can also see the SAP lying in that triangle. Now this is a new modality of imaging, what is called as fusion imaging, where you have a CT, MRI and plain X-ray combined together, and you will find that here, if you see this, those wings, those things coming up is the real ligamentum flavum causing the compression of the nerve. This orange thing is the nerve. This portion is totally unknown to the spine surgeons. I can guarantee you, you talk with any spine surgeon, he will tell you that ligamentum flavum is only interlaminar. It is only from one pedicle to other pedicle or whatever, which is wrong. This is actual anatomy. We have unnecessarily, unfortunately, totally neglected this. आपलं दुर्भाग्य आहे की आपण ह्याच्याकडे लक्षच देत नाही. कारण का तर कुणीतरी 70 वर्षापूर्वी ब्रिटिश माणसांनी आपल्या डोक्यामध्ये हॅमर केलेलं आहे, ligamentum flavum hypertrophy. What ligamentum flavum? Where? We have to dissect it. Now tomorrow when we do a dissection, I would show you this is the anatomy. This is what is important, not the anatomy which we talk about. There is one more sign in MRI which I wish my colleague had mentioned. This is called as a sedimentation sign. Now what happens is, normally the roots are seen like this in the MRI. This is normal. As the canal becomes narrow, the roots come like this. They are not sedimented. That is, normally they should be seen settling down in the dural sac dorsally. But in a patient who has stenosis, worse stenosis, extreme stenosis will be like this, a little severe will be like this, moderate will be like this, normal, more or less normal will be like this. This is a very good sign of stenosis on a cross section in the plane of the disc. Ideally, you should take a cross section, not a cross section, but a coronal oblique in the plane of the facet, so that you can see the ligamentum flavum better. So now quickly, a few more points which I will clarify. Indications for my surgery are discogenic back pain, axial or vertical, which I told you, or horizontal. Chronic, non-healing posterior annular tear is the cause, and persistence of the pain is because of trapped nuclear fragments in the annulus. Disc herniation from D12L1 to L5S1, central, paracentral, foraminal, extraforaminal, up migrated, down migrated, new, old, recurrent, everything can be done by this method. Lumbar canal stenosis, which causes claudication due to unstable or stable spine, and a facetogenic back pain can be denervated by our methodology. There is a different methodology for that. Now, I'll come to 2 or 3 issues which all of us must think very, very carefully, and therefore I'm going to just read this because this is very, very fascinating and this is very important. Visual evidence is compelling. Unlike an abstract measure of plasma glucose or blood pressure, a herniated disc can be seen by the doctors and the patients. Most people are uncomfortable with the uncertainty, especially regarding medical diagnosis. To reduce anxiety, patients, family members and physicians alike often request imaging tests just to be sure. Spine imaging plays an essential role in confirming diagnosis and planning surgery. However, with ever improving resolution, modern imaging uncovers even more than that are alarming but of no clinical consequence. I can quote you multiple papers where MRIs have shown extreme problems but the patients have been asymptomatic. Why? Because the MRI does not show inflammation unless you do a gadolinium scan or something else. And the last thing, such findings may distract attention from the actual issues and thus become red herrings, which are absolutely irrelevant. I'll tell you a practical example. One of my colleagues recently operated a very senior VIP who was unable to sleep for 2 weeks because of severe pain. He operated him endoscopically. The patient was relieved fully, 100%. Patient was very happy. He gave a party to the clinician and he gave a gift of some gold tie-pin and something. Then, after 2 weeks, one of the very good friend of that VIP patient came to see him in his home and said, "You know what? Have you undergone post-operative MRI?" The patient said, "No, there was no need because I'm okay, I'm perfectly alright, I can do everything." He said, No. You see, many times these surgeons will fool you. You must do an MRI. There the whole war started. He did an MRI. The MRI specialist reported that it is just same. Whatever was seen before is seen after. There is no change whatsoever. Now see the fun. The patient is fully relieved, 100%. No complaints whatsoever. The MRI is supposed to look the same. And now the patient is threatening the clinician that I will go to the court and I will file a suit and I will ask for that gold tie-pin back and all the gifts back and more. This is absolutely idiotic. You know why this has happened? Why this happens? It is because we clinicians have fed our patients with this knowledge that MRI is everything. Now days are not far when many of us are going to be sued because everyone will quote the MRI. The lawyer will quote the MRI. Everyone will only talk of the MRI. Please, please, please wake up. A time has come for us to start saying, please move away from images to symptoms. Please move away from fusion to non-fusion surgery where the symptoms can be relieved. This is just an addition where the patient has a post-operative fibrosis. There are grades of fibrosis, etc. The point why I am showing it, these can also be treated by endoscopic surgery. Now I have just added this slide for fun. You see the needle which I put inside is 1.2 millimeter in diameter. The guide wire which I put is 0.9 millimeter, 0.9 millimeter in diameter. The dilator single is 6.8, cannula is 7.6, scope is 6.8, working channel is 3.625. The instruments are 3.5 or 2.5 millimeters. The footprint at the foramen of everything is about 7 millimeters. And Cambine's triangle, as I mentioned, is 12 by 18 by 23, or in Indians 11 by 13 by 17. And skin incision is 8 millimeter. So we are talking of everything which is less than 10 millimeters or 1 centimeter. Now, lastly, 1 or 2 more slides before which I show you the video. I have now sat down and have come to a conclusion that if I can follow a system which I follow, this is my system where I have 7 modules in my system. Number 1 is public awareness, like what I'm doing today, making you aware that the world had changed. Please don't believe what was true 50 years back. Just forget it. It is absolutely obsolete. Number 2 is precision diagnosis, which I can do, I can show you. Number 3 is counseling. One of my counselors is here. She's a part of my team. You can ask her questions if you like. She can narrate to you or educate you about counseling. Her name is Miss Pallavi. She's sitting there. Number 4 is intervention, which I do, which is stitchless under local anesthesia. It does not harm the patient. If the patient is not relieved, okay, he can always go back to open surgery. I have 4% patients who may not be relieved by what I do. I tell them, okay, I'm unsuccessful. We can always go for open surgery. Number 5 is immediate post-op care. Number 6 is rehabilitation. Number 7 is feedback. The other parts of my modules is managed by my manager, who is Mr. Praveen, who is sitting there. Now, I hope I don't know whether this is going to run or not. Depression. We are looking at L4-5 with a central herniation, and then this is the herniation, and the herniation has left behind some space here. Now, in Indian patients, from the center of the disc to the back is always 7.5 centimeters. So if you go 7.5 centimeters outside and come at an angle of 45 degrees, you will hit the center of the disc. This is Pythagoras theorem, which all of us have learned in our geometry, but unfortunately because we are B group, we have left mathematics behind. Now, our target is postiannulus. So if you go a little outside so that you can come up, which is minimum 9.5 centimeters, then you can come like this at an angle of 20, you will hit the facet. In lateral or in sagittal you will see that, and there is one more correction to this. The correction is the spine is lordotic. So the entry in this disc will not be in this line, but it will be tilted towards the head because of the lordosis. So about 5-degree tilt at 4-5, about 10-degree tilt at 5-1 is necessary to start at the skin. So skin point is here and we go here. On the way we hit the facet. Once we hit the facet, we come back, raise our hand and go in. So here I am hitting the facet. Then instead of 20, I make it 25. I raise my hand and I go inside, and then I land very close to the herniation, where I have this collar of annulus which I can cut, and then I pull this herniation inside and pull it out. So this is called an inside out technique, and this is the very, very simple basis of my technique. Now I can tell you this is not rocket science. It is plain simple mathematics, but the problem is most of you have mathematics as an optional subject. So unfortunately you will not be able to do it if you don't find this proper. Now, I'm just going to show you, I hope it runs. Okay. Now, this is a video of my surgery where I've operated a patient who has a D12L1 disc herniation. What we are looking at is the epidural tissue, posterior annulus inside the disc. This is towards the abdomen, 12 o'clock is towards the back, 3 o'clock is towards the leg, 9 o'clock is towards the head. This is my grasper. This is the epidural tissue, epidural fat. Patient is fully awake. I'm going to ask the patient in between to cough, and you will see that the annulus moves and has a little bit of oozing. Now here I'm trying to use laser. This is a holmium YAG laser. Please do not believe anybody who tells you laser is useless or laser is outdated or laser is not used. They don't know anything. Just tell them keep quiet. Do not sort of make us confused. So here the laser is falling on this area where you see, like this laser pointer, there is a guide light called as Hene light, which is red. The laser is invisible. You cannot see the laser. Now here what I'm going to do is to ask the patient to cough, and you will find there will be some small ooze coming up here when the patient coughs, and then I will put my grasper and remove the fragment. Now here what I'm doing is the annulus becomes stony hard, especially because this has been a very, very long drawn problem. This patient was a male aged 28 with sexual dysfunction. He was investigated fully, but finally the only thing which was found was D12 level 1, disc herniation. Now see this. Now this is my grasper which goes in, and I am grabbing the fragment and pulling it out now, and that's a big fragment which comes out. So this in short is an intradiscal surgery, and this is, again I can tell you, this length from here to here is 3.625 millimeters. It has been magnified this much, so you are seeing a big thing. So this is a fragment which I removed. Now I will tell you that I am extremely precise when I do my surgery. Here you will find, you will see my cannula coming up inside. This is a posterior midline, this is the vertebral body, the disc. This is a cannula which is paraspinal, intramuscular, behind the psoas. It goes in the foramen and lands on the under the annulus. So this is the way we operate. This is a trick CT where we have modified the CT pictures into this movie, and then I have the last but one slide. This is my surgery which is shortened in about 4 minutes. The patient is a male aged 29 with very severe pain because of this herniation at L5S1. Patient had severe sciatic pain. So I'm just trying to explain to the patient what I'm going to do, and you will see my complete surgery in about 4 minutes. Actual surgery took about 29 minutes. So I'm telling the patient, I initially draw a line on his back. This is done under the C-arm. Then I draw a line along the disc space. I'm looking at the C-arm here. This is the horizontal line, that is the disc space. Then I draw a line which is vertical and tilted as per the lordosis, and measure the depth of the disc to the front of the disc, which is about 9.5 centimeters, and I take the same distance over here. And then this is the point of entry where I'm going to go in. I'm not going to go posterior midline. I don't come from the side, I'm on the back. I inject local anesthetic, put a needle which goes in the foramen here at 5.1. You can see the needle. Now there are objections. Can you injure the nerve? Absolutely no. In last 19 years, I have never ever had a nerve injury, never had a dural tear, never had a vascular injury. Maybe I'm lucky, but if you are precise, it never happens. Now here I'm injecting a dye which will show you the nerve root going down. Then I remove the stellate from the needle and pass a guide wire. Then I remove the needle and I take a small, you can see the nerve, that black thing was the nerve. Then I pass this dilator which is dilating the muscles, it goes in, and then I remove, you see this is the nerve, this is the dilator, then I tap the dilator inside. Now this is a painful part of the surgery where I tap it inside the disc. So that time I give local, more local, or I ask the anesthetist to give fentanyl or midazolam or tramadol. So now my instrument is inside the disc. Then I put this tube outside that dilator. So what I've really done is I've made a passage from the skin to the disc herniation part without cutting anything except the skin and the annulus. Now these are my instruments, the needle 1.2 mm, the guide wire which is 0.9 mm, then my scope which is 6.8 mm, 25 degree at the end. This is for attachment of camera, attachment of light source. This is a working channel, irrigation channel, Then I have the older instruments. This is a cannula which I put inside. There is a cut here, you can see it is called as a bevel, so that it allows me to see up, not straight forward. Then I have these two old T-fines to cut a hard tissue so that I can go inside if the disc is, even if the disc is like stone. Then this is a grasper which is 3.5 mm. This grasper goes through the scope and I grab the fragment and I remove the fragment. Now here what I'm going to do is to put this scope in that tube which I already put in, and the patient is awake. Patient and myself, both of us are looking at the TV, as you can see very well here. So the scope goes in, the patient is awake. Just to hide his identity, I have put these words. Myself and the patient is looking at the TV here, and we grab the fragment. When you're pulling the fragment, the patient gets pain, and the patient does like this. It's like the pain goes up and the pain goes off. So this is the fragment which I had. In the past we used to take a single stitch. Nowadays we don't. The patient's SLR immediately improves, and theoretically the patient can walk home. But we keep the patient for a couple of hours as to make him settle as far as the blood pressure and other parameters are concerned. So this was my, now there is 1 and 1. This is a surgery where I am doing a foraminoplasty, but I won't stretch your patience now. It will take about a minute. You can just see what I do. Quickly I'll just finish this. On the right side is the superior articular process, and I'm using a hook and a curette to scrape it. I mean, there is one more thing which I'll tell you. There is a misnomer in spine surgery called as bony hypertrophy. Now let me tell you, and all of you, I'm sure you would agree, that there cannot be bony hypertrophy because bones cannot grow after the age of skeletal maturity. What grows is soft tissue, which may become calcified or ossified. So there is no bony hypertrophy. There is nothing like bony hypertrophy. And what is the importance? The importance is, if you have soft tissue hypertrophy which is calcified or bony, you can scrape it. The parent bone is not growing. I mean the facet doesn't grow. The coating of the facet grows, etc. So this, this is what I will be scraping now. I'm just feeling it against the bone, and it's very easy, it's very simple. These are the local anesthesia. This is my last slide, just for the sake of few of my friends who wanted to know. We have one more program coming up, 15 to 18 February in Dehradun, March 15 to 18 in Ahmadnagar. These two are my websites, drgoreonline.com, drgore.website. And thank you very much for your very patient listening. Half of you who were awake, I'm sure they must have been enlightened. Those who were probably not awake should now become awake. Thank you very much.
Method of surgery. We people are not aware of such a beautiful surgery, which can be really giving wonder results. I think number of open cases has been done in large number. So number of post-laminectomy syndromes are piling up. So I just want to ask whether this technique can help those patients after a few years, they come back again with the backache, having MRI changes with the disc protrusion or the foraminal stenosis. So can this technique help here in those cases?
Here I would tell you something which is very important, but all of us have guarded it as a secret. The real basic thing which all of us should know and tell the patient is that we are not altering the natural history of the disease. We are just taking care of the symptoms. A patient comes to you with back pain, you give something, take rest, take this, take that, pain goes away. Patient again comes to you after 2 years and says, I have more back pain. You again treat with medication, the pain stops. Patient again comes to you after 5 years, then he says, now my pain is slowly shifting towards my buttock. Then after 1 more year, the pain shifts to the leg, etc., etc. Or the patient will come with knee pain or heel pain, where actually the origin is in the back. And since we don't tell the patient that we are only taking care of the symptoms, we are not changing the way your body functions. There are a lot of misunderstanding. In fact, on this point, all the open surgeons tell the patient, yes, guarantee, 100% all right, permanently, these screws will make you perfect. Absolute rubbish. Now if we tell the patient the truth, I think the bad blood between the patients and the surgeons will reduce considerably, that we are only treating your symptom. Your body remains same. I tell the patient like this, you see, my surgery is not to make you young. You are 50 years old, you will remain 50 years old today and tomorrow. You will not become 20 years old. Number two, your flexibility, your strength, your body posture, etc., 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 everything will remain same. I am only taking away the cause of persistent inflammation or compression. That's it. So, one more thing is that when you see a patient who, let's say, is 55, has a disc herniation, you should also do a foraminoplasty because you are already in the foramen. Then you can relieve him for, say, 15 years, 20 years, not permanently. And you should explain this to the patient, that surgery is not going to relieve you permanently. Second thing you have to tell him is that surgery at 5'1" doesn't guarantee you that 4'5" will not be affected. It is decided by your genetic code, not me, not the surgeon, not the clinician. So these few misunderstandings have to be clarified.
Any questions from the audience, please? We are going to observe him.
Surgery, I just had a query about it. If the L5 front disc is herniated, it is in the canal, we are doing it by inside out technique. Sometimes after, in a long standing process, the disc is hardened as you discussed earlier. The disc is hardened, and how it is possible to remove it from inside out? If the disc is sequestered in the canal, it has gone below it has gone behind the body and below the root. How do we do in that case? And if the disc is hardened, as you showed, the soft fragment came out easily. But sometimes when we are doing open surgery, even if you knock it down with osteodome, sometimes you have to use sharp osteodomes, even burrs, to remove that hardened fragment. So how do you do it while doing it endoscopy?
Okay, the answer is like this. You see, when you are dealing with a disc herniation, there are three types of disc herniation. You can sit down, no problem. The first type is what is called as a soft herniation, where you have a pure piece of nucleus which herniates. Now, if you have a pure piece of nucleus which herniates, and if the patient has pain which is manageable with root block or oral medication, I do not operate that patient. That fragment vanishes at the end of 2 months, definitely. Number two, you have a herniation which is called as a nucleus plus annulus. Now this is a fragment which also can reduce considerably in about 6 to 8 months.